Welcome everyone to today's webinar on integrating patient adherence into continuing professional development curriculum. My name is Amy Holthusen with Interstate Postgraduate Medical Association, or IPMA. We have several presenters today. These include Mary Alice, also of IPMA, Dr. Jack Keyes from the University of Cincinnati, Jan Balmer from the University of Virginia, and Tom McKeithen and Chris Larison, both of Healthcare Performance Consulting. Today's project is funded by an educational grant from Pfizer. None of the presenters have any relationships with commercial interests to disclose. To start us off, I'd like to present the Executive Director of IPMA, Mary Alice.
Continuing medical education has focused on helping physicians and other healthcare professionals get the appropriate therapy to each person at the proper time. Physicians and healthcare professionals work together through this screening, diagnosis phase, evaluating each symptom and the patient history to develop a treatment regime. And then what? The patient leaves the office with the doctor's orders in hand. 32% of the time, patients never fill the prescription. Prescription refills to manage chronic disease drop off precipitously after 6 months. Patients say they can't afford their prescriptions, that they feel better, that another healthcare professional told them to stop or change their dosage, or they simply forgot. The quote by Dr. Haynes of the Cochrane Collaborative summarizes our imperative. As the prevalence of chronic disease continues to increase, we have to understand the myriad factors that influence patient adherence and explore the role of the patient, the physician, the healthcare system in addressing this public health need. During this webinar, we, the principals of this project, from continuing medical education offices at the University of Virginia, the University of Cincinnati, as well as Healthcare Performance Consulting and the Interstate Postgraduate Medical Association, will present our needs assessment surrounding physician attitudes, desired knowledge, performance, and barriers to patient adherence. This assessment process included a literature review, a meta-analysis on hypertension, asthma, and diabetes, qualitative interviews, focus groups, change readiness inventory, and integrated evaluation of these findings. From these, our focus is on designing continuing medical education curriculum that addresses physicians' needs surrounding patient adherence. Next slide, please. Why study patient adherence at all? We all know it's a serious health issue, particularly in chronic disease management. We aren't implying that it doesn't exist in acute disease management, as anyone who's ever run a medication drop will tell you. But the adherence challenge is far greater the longer the patient is on a prescribed therapy. For many patients, it's looking at that therapy for the rest of their lives. Medical education, particularly continuing medical education, has focused on vertical therapy areas, for example, diabetes, cardiovascular disease, or asthma. Adherence, however, cuts across all therapy areas. There are some nuances reflecting the disease itself, the duration of the disease, and the delivery of therapy, but we wanted to look at a project where we were able to span many different vertical areas of medicine, be able to look for the similarities that may exist across different areas. During this project, we learned that adherence is not a good standalone topic. Physicians aren't interested in a day-long lecture on patient adherence. Therefore, we need another plan. We all know that adherence drives up costs. Prescriptions remain unused, therapy is modified based on non-response, follow-up visits are scheduled. Our society is acutely aware of these soaring costs. Adherence is yet one way that we can help address the rising costs of healthcare. Adherence is also a patient safety issue. Patients have doses or double them up when they forget. Physicians increase doses because they believe more aggressive therapy is needed. All of these compromise the safety of our patients. We believe CME professionals can play a significant role in providing faculty and course directors with this adherence framework. Ask your faculty how adherence might impact a case. Include an opportunity to practice open-ended adherence questions within your continuing medical education events. Bring together physicians and their teams to evaluate and assess ways practices can work together to support and improve adherence. We all have a role to play here. Before we move on, I'd like to say a word about the terms used in this project. While compliance is the most recognized term used by physicians, it's interpreted as physician orders irrespective of the patient's desires. Adherence and the more recent term concordance recognize the partnership that the physician and the patient have together. We use the term adherence throughout this project, recognizing its representation of the various words. Adherence is not a black and white term, but reflects many shades of gray. Virtually all patients, except perhaps my mother, fail to take their prescribed therapy at some time. Therefore, we stay away from the term non-adherence or non-compliance and work toward improving adherence. Thanks for your attending this webinar, and with this brief introduction, I'd like to pass the webinar on to Jack Keyes, the Senior Vice President of Continuing Professional Development at the University of Cincinnati. Jack will take us into the meat of the study and some of our initial findings.
Thank you, Mary. One of the things, as you might imagine, that we found as we looked at the issue of adherence in the literature is that it's quite diverse. It's spread across a wide range of clinical conditions, and it covers a number of issues within the concept of adherence. So in order to get a better comprehensive understanding of what is actually going on in the literature and what it's actually telling us about adherence, we did a couple of things. We began by looking at patient adherence within three clinical areas, as Mary identified them as asthma, hypertension, and diabetes. We chose those three areas because they represented chronic conditions where adherence to medical regimens and to physician orders are quite important to the long-term care for the patient. Within those areas, we noted that these are three slightly different types of diseases in terms of issues for adherence. Asthma being relatively straightforward in that most of the issues around adherence and prescriptions from physicians are related to the use of medication, in this case inhalers. When we move to something a little bit more complex, like diabetes, the issues for adherence also related to the patient's ability to monitor their own condition and moderate some of the prescriptions in order to maintain optimal health. And hypertension was unique in that there was very little symptomatic indication to the patient if they failed to adhere to the medication or any of the other orders from the physician. So beyond that, what we did is we looked at the literature in particular ways that allowed us to identify whether there were any effective interventions that would address issues of patient non-adherence. So we narrowed the ample literature to those studies that had an identifiable intervention, those studies that had an objective measure of outcome, of adherence, rather than patient report. We looked at a variety of other indicators of adherence that were more objective, and also those that were quantitative and sufficiently robust enough that we felt comfortable with the outcomes of the studies. And across the board, one of the things we noted was that the studies that met those criteria systematically excluded the physician from taking part in addressing issues of non-adherence. So the studies that we found, the intervention studies, used nurses, pharmacists, and a variety of other ancillary providers to contact the patient, to work with the patient. In some cases, they were using information technology such as the internet to be able to keep tabs on the patient and keep some engagement with the patient. But uniformly what we found is the physicians were excluded, and the results of the meta-analysis generally indicated that the different intervention strategies that were used were not especially effective in reducing long-term patient non-adherence. In many cases where these were regular weekly or daily contacts with patients, they were effective as long as they were in place, but as the intervention was discontinued, what we typically found was that the non-adherence rate went back up. So a couple of lessons learned here. One is that it is very important to engage the physician, that interventions that do not engage the physician are not found to be particularly effective. And the other is that across the board issues of non-adherence, regardless of the disease state, the interventions that had been tried did not seem to be effective long term. But while they were continued, there were some positive results in improving patient adherence. So those were the basic findings across all three clinical areas. One of the strategies we were looking for in both the literature and in discussing issues of adherence with providers was to identify the overall model and the key variables that sort of summarized issues of patient adherence. In the literature, we were only able to find one such model, and that targeted a very specific condition, that being HIV/AIDS. We looked at that model and compared it to the clinical conditions, the chronic conditions we were looking at, and found a number of flaws with it, and as a result developed this model. The one thing I want to point out in this model is that most of it is centered, the key potential for intervention and improvement centers around two triangles. One on the left that involves other providers, the primary healthcare provider, and the patient, and one on the right which is identified by the triangle including adherence, health outcomes, and external factors. So I want to spend just a minute looking at the triangle on the left and noting that one of the major issues there is trying to get to the point where the patient understands and is able to carry out the instructions of the physician and the healthcare provider. And this becomes complicated by a number of factors. One is the communication between the patient and the primary healthcare provider. Often there are difficulties in getting that message across, and many healthcare providers mistake patient education for addressing issues of patient compliance. What we noted is that physicians telling patients, giving them a prescription and telling them they need to take this daily or every 4 hours is not sufficient to guarantee or even to assess whether or not the patient is capable or interested in being compliant. In addition, the patient is likely to come in contact with a variety of other providers, including pharmacists and maybe dialysis clinic, physical therapists, and for that matter, there's a number of other information channels the patient has access to, from the media to relatives and friends and other people that may be freely interested in giving advice. So at the end point of that triangle of communication, the patient has a message. What we're not always clear on is what that message is, and from there the patient, we get into the issue of patients' intent and their motivation to be adherent. But even with the greatest intent and greatest motivation, if they do not have the correct message, the likelihood of them being able to be compliant is mostly related to accident. So the triangle on the far side that is really where most healthcare providers become involved in adherence is assessing whether or not the physician is able to or has been adherent to the medical regimen that they were put on by the healthcare provider. And that really falls into three basic categories. They are either taking the medication or the prescription or not. They are taking it in the timing modality or at the correct times that it's being prescribed, and they are taking it over time. So we are often familiar, and certainly practitioners are familiar, as Mary said, that about a third of prescriptions are not filled. When they are filled, there are often issues of the timing, patients being told that they need to take the pill 3 times, 4 times a day. There are a number of stories that we hear in the clinical environments where patients are taking them all in the morning or all in the evening or in some way contraindicated to the timing that is supposed to come into play with that particular prescription. And then there are the very frequent stories from clinicians of patients taking a medication until they feel better and then putting the rest in their medicine cabinet until they need it again. So there is the issue of adherence, but more importantly, what physicians look at are the health outcomes there at the bottom. If the patient is meeting all of the health outcomes expectations of the clinician typically will not go back and assess whether or not the patient was adherent, but will make the assumption that that's the case. The more insidious problem is if the health outcomes are not what the physician is expecting, physicians, rather than assess adherence, may make the mistake of assuming that the problem is with the prescription. They may double the prescription or change to another medication with the idea that they need something stronger or something different, when the real problem is one of patients not taking the pills. The health outcome problem there is if the patient then decides to become adherent, they may find themselves taking twice as much medication or the wrong medication, and then the health outcomes become problematic. Part of the issue, the third part of that triangle that we heard quite a bit about from the practitioners were the external factors that affect adherence on the part of the patient. These may be other medications that they're on, that may be the ability to pay or access to resources, being able to get to a pharmacy, or the complexity of the therapy where they're expected to do a number of different things. So this second triangle really sets up some of the assessment that physicians do after the patient comes back into the office. So I'm going to turn this over to Chris and Tom, who will talk to you a little bit about the interviews that they conducted with practitioners on this issue.
Okay, thank you. This is Tom McGeeson with Healthcare Performance Consulting, and the role of my partner Chris Larison and myself was to do some primary research around the needs of physicians in adherence and compare that to what was found in the literature and determine what that means in terms of medical education programs. So the primary research that we did was really two components. One was a series of interviews that we did, not just with physicians, but also allied healthcare personnel that are often a part of the adherence equation, as well as patients themselves. With the idea being to get a good 360-degree view of physician perceptions about their own needs and barriers relative to adherence, but also bring the voice of the learner, that is the physician, into this needs assessment process. So from the series of interviews that we did, we derived a number of themes, and the themes were stories and items that we heard from many different perspectives, and heard them often enough to think that we needed to take them seriously. So I'll go through these on the next couple of slides. The first one is that physicians know adherence is an issue, but they really tend to place the responsibility for adherence on the patient. So there's really no real sense of partnering among many physicians. We did find from the physicians that they feel like there are system barriers that get in the way of good adherence, and we'll talk about those in a few minutes. we found that physicians in general do not assess the potential for adherence or lack of adherence pre-treatment. In other words, when they are selecting treatments for a patient, there's really no attempt to assess the patient's ability to adhere to that treatment regimen. And likewise, when there is failure of a therapy, they tend to think of it as failure of the treatment or the drug itself and not as an adherence issue. So they don't think about it too much after the fact either. Their perception is that few resources or systems that would help with adherence are available. We know that that's contrary to what's out there because there are many resources available. So it's a perception that really does need to be dealt with in the context of medical education. And finally, on this slide, they do perceive that communication is really an important part of the adherence equation, which it certainly is. Going on to the next slide. Some additional findings from the interview. Physicians tend to spend more time discussing the purpose, the timing, and the side effects of treatment, and much less time discussing the consequences of not adhering to treatment, some of the interactions of treatments, and the need to refill prescriptions as ordered. And as was certainly found in the literature meta-analysis, non-adherence is much more of an issue with chronic conditions than it is with acute conditions, with the exception being pain. Moving on to the next slide, the second part of our primary research beyond the interview process was to develop a survey instrument. And within that instrument, we collected data about some of the barriers that were known as being barriers from both the literature and the interviews. And when we look at this slide, you can see that there's on the order of 9 barriers there. And from the physician point of view, there's only 4 of those barriers, the first 4 to the left of the slide, that are even over the midline for this 5-point scale assessment. So if you look at the level 3 line, that would be neutral. In other words, it's right at the midline of whether it is a serious barrier or not. And so physicians are kind of neutral at the 3 level. So in general, they do not perceive a lot of barriers to treatment, but the ones they do, you can see are very much system barriers to a large degree. The lack of time to deal with patients and adherence issues, formularies and medication costs certainly could be considered system barriers. Low health literacy, system or patient barrier, depending on how you look at it. So I think the key message here is to understand what are the barriers that do apply to your particular physician target audience, and make sure the ones that are real barriers are certainly addressed, but also find out however you can, either by a needs assessment that's particular to your physician audience or through something like an ARS, to find out what their perceived barriers are and get an understanding of that and try to deal with those within the context of the educational activity. You can also find a lot more detail about these interview themes as well as the physician barriers in the complete needs assessment report that's online at the IPMA website. Moving on to the next slide, which deals with aggregate physician barriers. So these are the barriers that were derived not just from the primary needs assessment research, but also the literature. As Mary pointed out earlier, physicians are really not interested in this topic as a standalone. It will be received much better as part of a clinical topic. They do perceive adherence as a patient problem, not so much a physician problem. So that is a perception that does need to be dealt with. and show them that there are ways that the physician can help their patients to improve adherence. Third bullet point on this slide, they really don't perceive that they have the skills and resources to change patient behavior. And so it's important to address those skills and provide those resources where you can in the context of your educational intervention. And many physicians really think that they're doing a pretty good job. And so you might look at that as sort of a potential barrier to changing behavior. They already think they're doing a good job, and you know from your own needs assessment that in a particular clinical area they are not doing a good job, then they need to be shown some data around that to know that there is room for improvement. And finally on this slide, addressing adherence really needs to be a multidisciplinary approach. As Mary talked about in the beginning, it's not just a doctor issue and it's not just a patient issue. It's really the whole medical team, including family and caregivers that are involved in improving patient adherence. And so touching all of those stakeholders gives the best chance for improving adherence. Another part of the primary needs assessment survey was to look at perceived needs or competency gaps among physicians. And where they feel like they really need help through medical education is how to identify poor adherence in their patients. They really don't have a handle on that. We talked about the fact that they don't really assess adherence or potential adherence before they treat a patient, and yet that's where they can identify barriers to adherence. And so they really need some skills in how to identify patients that might be adherence challenged, let's say, and remove some of those barriers before treatment even begins. They feel like they do need help in enlisting ancillary healthcare providers in order to build that team that helps the patient comply. And finally, they think that they do need help identifying resources that will help patients comply. Now, it's important not only to understand their high perceived needs, but also to understand their low perceived needs. Because where they have low perceived needs or low gaps, where that is in conflict with the literature, really is an important area that needs to be addressed, because otherwise they will not be motivated to pay attention to those areas. They really think they're doing a pretty good job providing simple, clear instructions to patients. But yet when you look at the patient literature or talk to patients about this, they will readily admit that they will sit there and when the physician says, "Do you understand these instructions?" they'll say yes, because they do understand the instructions at the time. But when they go back to their house and try to comply with the instructions, they realize they really didn't understand them the way they thought they did. So this is an area that needs work. Physicians also feel they are pretty good at customizing the regimen to improve adherence. And in fact, when we talked with physicians about what they do to improve adherence, most of the conversations were around this issue exactly. So maybe they are pretty good at this. Essentially what they mean when they talk about customizing the regimen is really trying to move from twice a day or 3 times a day therapy down to once a day therapy. And finally, they feel like they're doing a good job at ensuring patient understanding of their instructions. And again, when we talk to patients, the picture is a little different. So this is an area where they don't think they need much help, but in reality they do. So that is the end of the discussion on physician perceived needs, barriers, gaps, and so forth. And I will turn it back to Jack.
You got me. So in order really to synthesize all of the data both from the meta-analyses, literature review, and the interviews into something that is applicable to the practicing clinician. We identified a rather straightforward, simple two-part model that identified the really two principal components of addressing adherence in a clinical setting. This is the diagram that you see in front of you that really focuses on assessment or asking, and on the back end of that being able to adapt your own therapy and patient education and recommendations to the patient to be able to accommodate some of the findings that you get when talking to your patient. So this model of ask and adapt is really put into place throughout the encounter with a patient. It isn't something that is only done when you first prescribe something for the patient, and it isn't meant solely for the follow-up visits where you're trying to assess whether or not the patient has followed through with your orders. So it really is something that crosses both of those areas and any contact that you have with them in between. So on the front end, as we talk about the asking part, we're really looking at having the practitioner engage the patient and on the front end to have a short conversation before they leave the office. And while we have really focused on the physician having this conversation, we recognize in a busy office it may be another member of the healthcare team. But really what you're looking for is to find out, to assess what the patient and the patient's family need to know about the therapy that you've prescribed. And there are a number of things. I think physicians are very adept at explaining that they need to fill this prescription, that they need to take it this many times a day. Many physicians spend a great deal of time going through taking the medication with food or not with food, some of the possible consequences of taking the medication, some of the side effects. But we really think that in order to fully assess issues of adherence, that the conversation needs to go beyond that. In fact, a number of those kinds of issues can be substituted for some of the things that will get you a better assessment of the patient's likelihood to follow through. Asking the patient to repeat back to you the instructions, talking to the patient about what happens if you do not take the medication or if you do not take it as ordered, helping the patient understand, how to overcome mistakes. I forgot to take my pill last night before I go to bed. I was out of town or I was busy and I forgot. Now what do I do? And often patients find themselves trying to be adherent and not having the information that they need. So being able to assess whether or not the patient can understand the purpose of the medication and the purpose of the orders and the details of the orders is very important. Also, documenting this communication can be very helpful later when you talk to the patient on a return visit, so that you can identify some of the issues that are some of the risks that you may have that you may have uncovered when you first talked with the patient. So the assessment piece, the asking piece, certainly when you first prescribe something, is aimed at being able to determine whether or not the patient is a likely risk for adherence. Some of the risks are certainly become very apparent. If this is the 7th or 8th medication you've put this patient on, or if this is a particularly complex medication, or if the side effects are particularly onerous, these are all risks. If it's an expensive medication, all of these things are things that we suggest be assessed up front. The adapt part of this model, this two-part model, is also really a guide to the physician to be able to make some modifications to what they're doing in order to accommodate a patient that's at risk. There is always an ideal medication for a particular patient at a particular time, but if this patient is at a high risk for non-adherence, whether it's because they can't afford it, they can't understand how to follow through on the instructions, or there are some other shortcomings with the medications that you prescribe, then physicians are often in a situation where they may have to adapt an ideal medication or an ideal regimen to something that may be less ideal in order to address the issue of adherence. So with the issues of adapting, often you have to customize according to the patient's wishes or needs. You may have to spend extra time providing instructions where the feedback you get from the patient is that they don't fully understand what they're doing. You may need to spend a little extra time enlisting other healthcare providers or family members, other people that can assist you in increasing adherence, and then again be able to assess that in follow-up visits. So while it's really just a two-part model of asking and adapt, it does require continuous engagement with the patient, and this is what we find that this is where problems with adherence often begin, is that the communication between the practitioner and the patient is not as complete as is needed, although the physician may feel perfectly comfortable that they have adequately explained and followed up with the patient about a particular prescription. What we often find is that there are holes in those in the instructions, or holes in the assessments of whether or not the patient is actually adherent. So it really is a fairly straightforward model, but it does require the physician to pay more attention to both risk and the need for the physician to adapt in order to address adherence complications. So here are some of the questions on the ask side. I mentioned some of these. You can see that this really is a much more comprehensive assessment than practitioners are typically able to obtain from a patient, and yet these are the kinds of issues that we found are most frequently related to adherence problems, at least from the patient's point of view. And on the adapt side, I mentioned a number of these. You can see that these are things that physicians either can do or may find themselves having to do in order to address some of the specific risks that exist for non-adherence with the patient. Okay, educational implications.
I think that's me. This is Jan Ballmer. I'm moving on to educational implications. As we design educational activities that are incorporating adherence as part of an educational discussion, these things can actually be incorporated into the medical management or treatment protocols in almost any therapeutic area. And what we believe is that adherence, because of its form and structure, is actually applicable in any CME activity that speaks to improving patient care and performance improvement. So the kinds of things that you want to incorporate when you think about adherence, because in many situations your physicians will be clinical experts in a specific medical domain or surgical domain or in relationship to a particular therapeutic area, but they may not in fact be experts in patient adherence. So one of the things that we want to talk about are ways to emphasize adherence by addressing patient safety concerns and the lack of therapeutic effectiveness. Jack has spent some time talking about those things today, and I don't want to reiterate all of this, so we'll move on. But non-adherence complicates and confuses the clinical assessment. We've talked about that a little bit. It is critically important in an educational setting where you can actually provide cases or sample questions and other kinds of scenarios in a way that makes good sense and gives physicians an opportunity to sort of mentally register or mark that area so that they can think about those situations, so that if a patient comes in and their therapeutic the dose that they thought was therapeutic is not getting the desired results, then it may actually trigger some conversation relative to the patient's ability to follow the directions, get the prescription filled, those kinds of things that they may not have considered prior to moving it to a higher dose or selecting another alternative. The cases should also include, though, the patient fails when they have been compliant. We don't want to solely assume that patients always forget to take their medication, and sometimes some therapeutic alternatives really do not work, but we need to be able to have the physician and his or her healthcare team actually assess whether it is an adherence issue or whether it's a therapeutic issue. The education should also address appropriate communication skills through probing questions, and there are non-threatening opportunities and discussion points throughout the entire visit where the healthcare staff can actually ask patients questions about taking the medication, how did it work, when did they normally take it. Those questions can be asked by a nurse's aide or a nurse or as well as the physician in order to make sure that they've got some consistency of data. So from an educational design perspective, how would you integrate patient adherence into your educational strategies and activities? Take a few minutes and think about it. Are there specific things that you could incorporate into your current educational activities that would, in fact, speak to some of these adherence issues that you hadn't really considered before? Some of the examples of things that you might want to consider is the use of multidisciplinary panels. We know from the research that patients will also oftentimes tell a pharmacist or a nurse or a nurse's aide or a physical therapist different information than they will provide to the physician. And so we need to make sure that we're capturing that data, which is speaks to the communication and the team approach that Jack mentioned earlier. Case studies are an excellent way. I think that's another way also to do some benchmarking and determine. You can use an audience response system and other kinds of systems to actually find out if, in fact, what kinds of activities the audience is utilizing, if, in fact, they're asking reasonable questions or questions that speak to adherence. Discussing strategies, what works. There may, in fact, be some generational differences. There were cultural differences. There are a lot of issues that need to be thought about when you talk about communication and implementation strategies in terms of getting to the issue of patient adherence, because it also relates to the issue of health literacy and how well does the patient understand exactly what it is that they've been asked to do. There are a number of other strategies as well. You can put them in small groups. You can do role-playing and other kinds of things that help to foster that discussion and integration of patient adherence as part of a larger system as opposed to a self-standing topic. So one of the things that we've done is create a guide to integration of patient adherence, and what we've done is create some sample questions that maybe can help guide some of the CME discussions. So one of the questions you as a CME provider or as a CME designer and developer may want to consider is, before the patient leaves the office, what does the patient and family need to know about the therapy that you've prescribed? Almost across the board, the physicians could answer those questions for us if we ask the physician. The interesting point is that if you ask the healthcare team or the patient, that information may not be the same on the receiving side. Who's responsible for communicating the plan of care and the critical messages that impact patient adherence? The reality is that probably more than one person needs to do that, which forces some kind of communication mechanism within the office. Text messaging, electronic medical records, prescriptions, whatever, a checklist on a chart. There are any number of strategies that can be used that can actually foster the communication. How do you document it? We've just talked about a couple of those ideas. And is there a mechanism for follow-up with the patient to assess adherence? This is particularly important because we need to know, one, how it's getting communicated during the initial visit, but then when the patient comes back for a subsequent visit, how are those issues actually being addressed? And can you, in fact, go back and see what the interventions and the discussions were with the patient at the original visit? What information do you want to know when the patient returns for follow-up? All of those things create this wonderful continuum of communication that is particularly important in the patient adherence area. So the other thing that we've done is create some example cases. There are several cases in this packet that provide initial assessment as well as follow-up assessment. We have here a 40-year-old woman who's referred to a cardiologist, and what we've done is create a series of questions that can be utilized as part of this case scenario. They can be done as audience response questions. They can be done in small groups. They can be done as role-playing. Each case does not have a comprehensive set of questions because that would get long and probably somewhat onerous in terms of an educational design. So what we've tried to do is highlight at least some of the issues in each of the cases. So does she understand what hypertension is and the health impact of hypertension? Does she know what her goal blood pressure is? Does she have insurance? How will she integrate this medication into her life? Does she understand the potential side effects? Does she know where to call if she's got questions? Will she take this medication, and how is this information transferred to her PCP? So those are just a sampling of questions. It's not an exhaustive list, but it does provide us with a framework for ongoing discussion. So all of these things together then create this wonderful circle that Jack has already talked about. But now you see that the circle has two sets of arrows. The first set of arrows speak to the initial conversation that you have with the patient, and then the second set of arrows are in fact the follow-up and the monitoring of the patient and patient adherence and the ability of the proposed and mutually developed plan of care into the regime for the management of the patient with a particular disease process. And it's particularly important in chronic disease conditions where the follow-up and the continuity and the consistency of the patient adhering to a particular regime is exceptionally important. So the other thing that we have created for you is a series of questions that can be self-assessment questions that you can use as parts of an educational activity. I'm not going to read through all of the questions, but I will highlight a couple of them. What percentage of your patients have difficulty adhering to your prescribed therapies? How often do you assess patient adherence at follow-up? And how often do you verify that the patient understands what they need to do and why they need to do it? There are more questions than that here on the slide for you, but they do provide you with a framework that can be relatively consistent in terms of self-assessment and overall office and micro-system assessment in terms of what you're able to do. So what our expectations is that you include ask and adapt into your activity, and then you assess the effect of that strategy on not only the physicians in your educational activity, but then do some follow-up with them to find out how well they're able to translate that into their particular practice setting. I'm going to pass this on back to Mary Alice.
We hope this webinar has given you some ideas about how you might adapt system-level changes into your own activities. I think you can all imagine a situation where you're doing an activity on asthma, and it's appropriate now to understand how a patient may take their asthma medications. Do they understand how to take it? Do they understand long-acting inhalers versus quick immediate relief inhalers? Do they understand how to get it refilled? Do they understand who to call if they have any questions? And the value of that sort of interaction is that we're doing more than just improving medical knowledge. We're giving physicians and other healthcare professionals tools that allow them to integrate that knowledge into practice behavior, into communication, into systems changes and systems analysis. And if any of those themes sound familiar, those are themes that are being supported in the AVMS competencies. And we are all being challenged as CME professionals to get beyond medical knowledge and really provide tools and skills that physicians can use to really transform their practices. We hope this webinar has given you an opportunity to think a little differently. And rather than just think about it, though, we'd like to challenge you all to go and take some of the tools that we've mentioned and use them in your own activities. We'd like to give you a website, which is www.IPMAmeded.org. It's listed. You'll see it listed here under the contacts.
Because on that website you will find a detailed needs assessment that includes the interview results we've discussed. It includes the meta-analysis on hypertension, asthma, and diabetes. It includes a detailed literature analysis, and it includes results of survey instruments that we've used. We invite you to take any of those and use them in your own activities, use them for your own education. In addition, there is the toolkit that we've mentioned. In that, you will find resources on needs assessment. You'll find barriers. You will find physician competencies related to adherence. You'll find these cases that Jan and Jack have mentioned, which allow you to take some simple cases that you might be familiar with and figure out how you might integrate adherence into them, both upon initial assessment of the disease and upon follow-up. And we invite you, and in addition, the slide that Jan showed with the questions, we encourage you to take those questions and weave them into your own activities so that you might look at including patient adherence. We thank you for your time. If you have any questions at all about anything that's been discussed, you've got our names and our phone numbers and email addresses. We encourage you to contact any of us. We really feel that this is an opportunity for CME professionals to really relate to their faculty in different ways and allow us all to challenge our own profession as we look at our own competencies in terms of how we might think differently about the role of of our CME professionals in medical education. Thanks very much, and hope you've enjoyed this webinar.